Good morning, everyone. And first of all, I would like to thank the organizers and Dr. Prashant sir for giving me this opportunity to speak on this topic. Really very vast, and it's really challenging for me to finish the topic in time because, as always, the art is long and life is short. This proverbs stays true everywhere. So, first of all, before proceeding to the main idea, part of like because at the top you will call aspects especially related to technology, which will be approaching to a case of lymphoma. So this is a very important question: which lymph node to be selected? Like it should be kept in mind that whether the clinician is dealing with a reactive process or a neoplastic process. Like cervical lymph nodes in children, they may reach up to 1 to 1.5 centimeter, and they may still be normal. And similarly, in adults, inguinal lymph nodes may not be just only large; they may be firm also, and generally they are densely adherent to the fascia underlying the inguinal ligament. So the inguinal lymph nodes in young adults may be very large and they may be firm. Similarly, the laborers or workers working in the fields, they may have large axillary lymph nodes. So one should know the neoplastic aspects and the reactive process, whether we are dealing with the reactive process. So a generalized lymphadenopathy should be focused upon along with the presentation like weight loss and the classical B symptoms. Localized lymphadenopathies are usually reactive and should be looked in a different manner. So sometimes there is radiology also helps a lot. I would like to discuss a small scenario which we came across few days back. There was a patient who was 26-year male, and he had generalized lymphadenopathy, and the patient presented with TLC of around 50,000. So that patient had because generalized lymphadenopathy was there, and obviously the accessible and palpable lymph node was the cervical node, and the cervical lymph node was FNAC'd, and then it was biopsied. Both times it was reported as reactive. It did not respond to antibiotics. Subsequently, when the patient came here, Dr. Pravas sir went for FDG PET scan. PET scan showed significant avidity in the inguinal lymph nodes. Then the inguinal lymph nodes were targeted and it was biopsied. And that showed the pathology. And the case turned out to be a PTCL. So selection of the lymph node is very important, and radiology helps a lot, and the clinical sense also helps a lot. So it should be a multidisciplinary approach towards which lymph node should be excised or which lymph node should be biopsied. So that is a very important aspect. Now the next important step which comes is whether it should be excised or it should be or a needle biopsy should be done. Ideally, for a pathologist, an complete excision with intact capsule is the best specimen for a pathologist, because it gives us a lot of plethora of findings which need to be studied, like the capsule. What is the thickness of the capsule? How are the sinusoids? Are there follicles or not? Is the pattern is diffuse or not, or is it follicular? If is there is infiltration beyond the lymph node, or it is going, or the abnormal lymphocytes are going in the adjoining soft tissue or not. So all these findings are possible only in an excision biopsy, but not in a needle biopsy. Uh, but sometimes we are limited with the like the lymph nodes which are deep seated, like those in the retroperitoneal or mediastinal or perihepatic or periportal nodes, which are large enough, which are displacing the viscera, and they're not able to excise. So we have to go for needle biopsies. And the needle biopsies, definitely they are superior technique for those lymph nodes which are deep seated, and they are definitely less invasive, and the patient escapes the invasive procedure of laparotomy. But again, needle biopsy has its own challenges. They are less successful in identification of the non-neoplastic process, especially the cases like SLE or even tuberculosis may become very difficult to diagnose in a needle biopsy, which is a deep seated. Similarly, like Kikuchi or Kimuras or these necrotizing histiocytic lymph nodes are become difficult. In fact, I would say that the non-neoplastic lymph nodes become even more difficult on needle biopsies. Then needle biopsies have a significant technical artifacts, like they show crushing artifact, like we can see here. This is crushing artifact because of the fibrosis, associated fibrosis. So in this crushing artifact, neither the IHC becomes discernible nor the morphology. So definitely both have their pros and cons, and it should be decided with all the aspects taking care in the mind. And the pathologist should not be pressurized upon to give the complete diagnosis, because these needle biopsies have their own challenges. Now, core biopsies are particularly useful in these scenarios, like when we have to stage the lymphomas, when we have to identify the recurrence of the disease, or we have to see the response to treatment. The pathologist should also look after some important points, like sufficient sections should be cut within the first go for morphology and as well as IHC, because recurrent cutting of the blocks leads to loss of the tissue, and we have to preserve the tissue as much as possible so that we can preserve the tissue for ancillary studies like molecular testing, etc. And similarly, when there are multiple cores, the cores should be divided into 2 to 3 blocks, so that the pathologist can restrict for the diagnosis and immunohistochemistry for one block, and the another block can be sent for molecular or fish analysis. And the IHC panel should be suggested after a good amount of work on morphology and clinical scenarios. Usually or normally, the lymph nodes are sent in 10% formalin, which and the volume of which should be 10 times the size of the lymph node. But if the clinician has time and he can coordinate with the surgeon and the pathologist, the best specimen is to send the lymph node as unfixed or without any preservative. And immediately the pathologist should take thin slices of these lymph nodes, and the imprint smears should be made. And these imprint smears are very useful. It can provide help in two ways. Like the pathologist can immediately stain these imprint smears to give a rapid diagnosis, and it will help in checking the adequacy of the lymph node as well. And then the few smears, they can be kept frozen. They can be kept preserved for fish analysis. So imprint smears can also be done for a diagnosis of lymphoma. And later on, after making the imprint smear, the lymph node can be routinely processed. It should be fixed in 10% formalin, and later on it will be blocked and sectioned as usual. So so this was a general part which I wanted to stress upon. Then coming to the this basic thing, I would like to stress upon where the expression of this starts and where the expression disappears. Like Dr. Nupur have already discussed the progenitor B cell and pre-B cell. Then after pre-B cell, it forms the immature B cell. These immature B cells are positive for CD5 and surface IgM and surface IgD. Now these naive B cells, either they undergo T cell independent maturation outside the germinal center and they directly form the memory B cells, or these naive B cells which are IgM, IgD and CD5 positive, or they home the mantle cell of the lymph node. Here we can see this is a lymph node follicle and the surrounding darker zone is the mantle zone. So these naive B cells home the mantle zone. This mantle zone, which are CD5 positive cells, then they enter the germinal center. This germinal center is very important because two important processes happen here. One, the switching off of BCL2 expression. So now we have to know that BCL2, importance of BCL2. BCL2 is an anti-apoptotic molecule. So when the BCL2 switches off, that means that the lymphocytes within the germinal center, they are prone to undergo apoptosis. So apoptosis will happen in the germinal center. The germinal center has two different zones, which is dark zone and the light zone. The dark zone has centroblast. Here we can see the dark zone and the lighter zone. The light zone have T cells and dendritic cells or antigen presenting cells. Now these centroblasts, after transformation after the IgH gene rearrangement, they transform to centrocytes. Now these centrocytes roll on these cytoplasmic processes of these antigen presenting cells. Now those centrocytes which have high affinity for these antigens, they will survive, and those which have less affinity, they will undergo apoptosis. Now the translocation of 14-18, which happens in follicular lymphoma, that leads to constitutive activation of this BCL2 expression. That's why these cells do not undergo apoptosis, and they get the survival advantage, and they persist. That's why in a follicular lymphoma, we don't see the tangible body macrophages within the germinal center. So this is very important. So the two important things which are happening in the germinal center is that the centroblasts are transforming to centrocytes with the help of IgA gene rearrangement, and there is switch off of expression of BCL2, which makes them susceptible to apoptosis. Then after when these centrocytes with high affinity maturation, then they leave the germinal center and they transform to memory B cell and later on long-lived plasma cell. Discussing the few important IHC expression markers like CD19, CD79A, and PAX5. These are the three most important markers of B cell differentiation, which starts from very early stage and they persist for the longest duration. Like CD19 starts from pre-B cell stage and it remains positive even in some subsets of plasma cells. CD79A again remains positive throughout the cycle. PAX5 also remains throughout the positive, but it switches off at the stage of plasma cell. But CD10 is different. CD10 remains positive within the bone marrow. It becomes negative here, but it becomes again positive when the cells enter the germinal center. So CD10 and BCL6 are the markers of germinal center, and they are markers of progenitor and immature B cells when the cells are in the bone marrow. Then BCL2, as I said, that BCL2 switches off its expression when the lymphocytes come in the germinal center. So BCL2 will be negative in a normal germinal center, while all the cells which are outside the germinal center will be positive for BCL2. So these are the location-based classification, although it's not very specific, but yes, most of the teachers, most of the faculty members have discussed already these aspects. So immunohistochemistry, earlier when the immunohistochemistry were not in so much common in existence, at that time only the small or large or very vague classification used to persist. But I'm sure the days will come when the immunohistochemistry will also be outdated, and the days will come only for the molecular. But yes, still the immunohistochemistry is the sole basis of differentiation. I will go a little bit fast here as we have discussed most of the points. So CD20 is the most widely used pan B cell marker. Its expression stops just before the plasmacytic differentiation, and they are positive in CLL, SLL. PAX5 and CD79A should be used when the rituximab have been used, because rituximab CD20, so it leads to loss of CD20 expression. So it should be supplemented by other B cell positive markers like CD19, 22, 79A. CD19 has the maximum range, I should say, that they remain positive from a very early to till late stages of maturation. Then coming to the PAX5, PAX5 is very important in Hodgkin lymphoma. Hodgkin lymphoma, earlier the cell of origin was not known, but Hodgkin lymphoma is the only one lymphoma which is an extreme example of discordance between the genotype and the phenotype. The Hodgkin RS cells, which are the neoplastic cells, they are actually the B cells, but they do not show any of the B cell marker. So they switch off the B cell program and they only show PAX5, and that too with dim positivity. So PAX5 is very important for Hodgkin lymphoma, the RS cells which show dim positivity. PAX5 is also helpful in differentiating the lymphoplasmacytic lymphoma versus plasmacytoma. It's positive in lymphoplasmacytic lymphoma and negative in plasmacytoma. Sometimes unusual positivity can be seen in lymphomatoid papulosis, ALCL, and small cell carcinoma. CD79A, we have discussed that it has the broadest sensitivity and it remains positive from precursor cells till the late stages. CD10 and BCL6, we have discussed that they are the markers of follicular center. So CD10 and Dr. Sehgal also have discussed in the last presentation, CD10 and BCL6 are the markers of, yes, there is one important aspect, angioimmunoblastic T cell lymphoma, which is a lymphoma of T follicular helper cells. They also express CD10 and BCL6 because they are homing the germinal center. So within the germinal center, the light zone have antigen presenting cells, which are the dendritic cells. They have the T cells and they have the centrocytes, while the dark zone in the germinal center is composed entirely of centroblasts. So this has to be kept in mind that the T cells within the in angioimmunoblastic T cell lymphoma, they are also positive for CD10 and BCL6. So BCL6 is basically involved in germinal center formation, and it helps in the immunoglobulin gene rearrangement. Yes, this is important. I would like to discuss one aspect. The presence of CD10 lymphocytes and groups of BCL6 positive small lymphocytes, yes, outside the follicles. That is also important. In follicular lymphoma, the CD10 positive cells, they spill over out of the follicle and they come in the interstitium as well. Sometimes the T cells which are present within the germinal center, they also express BCL2. As I said, the BCL2 switches off its expression when the B lymphocyte enter the germinal center. But the germinal center also have T cells. Those T cells express BCL2. So the pathologist should able to differentiate that whether the BCL2 positive cells in the germinal center are the T cells or the B cells. Definitely in a follicular lymphoma, BCL2 will be diffuse and strong positive. And in a normal germinal center, the T cells which are showing BCL2 positivity will be very less, or they will be scattered in the lighter zone. So as I said, that CD10 is positive in the bone marrow precursor cell. So the follicular lymphoma involvement in bone marrow should not be misdiagnosed by seeing the stromal cells CD10 positivity. So it should be present in the form of nodular aggregates or paratrabecular aggregates, and should not be confused with the stromal cells which are showing CD10 positivity. Yes, these are the pictures of BCL2. We can see this is the reactive follicle, and the small scattered number of BCL2 positive cells, these are actually the T cells which are expressing BCL2. Here, this is the reactive follicle. The BCL2 is positive outside the germinal center. So there is switching off of expression of BCL2 within the germinal center. And in a follicular lymphoma, we can see this is a nodule. The nodule and the interstitial, the paracortical cells or the interfollicular zone, all are BCL2 positive. CD5 and CD23. CD5 is positive in the cells which are outside the germinal center, like the one which are positive for IgM and IgD. So the mental cells and post-germinal center cells will be positive for CD5. CD23 is a marker of follicular dendritic cells, and they're positive in CLL, SLL also. So CD5 positive, 23 negative helps in differentiating the cells which are monocytoid or small lymphocytes, to differentiate the mental cell lymphoma and CLL, SLL. Then OCK2 and BOB1 are also very helpful. OCK2 and BOB1 are helpful in differentiating three lymphomas: Hodgkin lymphoma, primary mediastinal B-cell lymphoma, and NLPHL. So all the three mimickers are very close mimickers of each other, and they all arise from the mediastinum. NLPHL may not be necessarily involving the mediastinum, it may be outside. But yes, OCK2 and BOB1 are positive in NLPHL. It is negative in both Hodgkin and primary mediastinal B-cell lymphoma. We will come to the primary mediastinal B-cell lymphoma. So these are basically the markers of B-cell differentiation, and they are negative in Hodgkin RS cells. So a diagnosis of Hodgkin versus NLPHL must include the panel containing OCK2 and BOB1. Now cyclin D1 and SOX11. These two are very important markers for mantle cell lymphoma. Everybody know that. But SOX11, which one to prefer? Obviously, SOX11 should be preferred, because sometimes the translocation which is 11, 18 here in mantle cell lymphoma, sometimes the fusion partner is CCND other than CCND1. CCND1 marks for cyclin D1. But when the translocation partner is CCND2 or CCND2 or CCND3, then cyclin D1 can be negative. But even in those cases, SOX11 remains positive. So SOX11 should be supplemented, cyclin D1 should be supplemented with SOX11 for diagnosing mantle cell lymphoma. Then MUM1 is a very, actually it's a very non-specific. The broad term which should be used for MUM1 is actually the activated B cells. Once the lymphocytes move out of the germinal center after all the antigen exposure and they are transforming to memory B cell or plasma cell, then they start showing MUM1 positivity. And it is helpful in classifying the DLBCL, whether it is germinal center B cell type or activated B cell type. So it is, once the lymphocytes which leave the germinal center, it will come to be MUM1 positive. So the activated B cell type of DLBCL will be positive for MUM1. So these are positive in post-germinal center. Post-germinal center will be negative for CD10 and BCL6, which are markers of germinal center, and MUM1 will be positive. Similarly, lymphoplasmacytic lymphoma can be MUM1 negative and instead PAX5 positive. Some exceptions are always there. And lymphomas with MUM1 positive expression are Hodgkin lymphoma. The B cells, the neoplastic HRS cells are positive for MUM1. Primary mediastinal B cell lymphoma, ALK positive large B cell lymphoma, plasmablastic lymphoma, cutaneous ALCL, primary cutaneous large B cell lymphoma, and EBV positive. Actually, there is a long list, but we will try to restrict. CD30. CD30 is again very important marker. It is shown in activated B cells, T cells, NK cells, and monocytes. The Hodgkin RS cells are the most important. It is positive in ALCL. ALCL and plasma and primary mediastinal B cell lymphoma. ALCL is very important to assess. CD30 is very important to assess the ALCL. It should be diffuse and strong positive. Otherwise, it cannot be ALCL. Similarly, primary cutaneous, it's very important in cutaneous T cell lymphomas. Mycosis fungoides being the most common, the second most common is the cutaneous lymphoid papillosis, lymphomatoid papillosis, which are CD30 positive. So CD30 positivity is plays a role in Hodgkin lymphoma. All the large cell lymphomas, or which are EBV driven lymphomas, all the EBV positive lymphomas show CD30 positivity. Then CD15 is Hodgkin lymphoma. And granulocytic sarcoma, I came across a case which was who was diagnosed as a mediastinal mixed germ, and then later on, after 3 months, patient presented with lymph nodes, and those lymph nodes were showing CD15 positivity and were negative for all other B cell differentiation markers. I was surprised to, and I could not delineate the what the diagnosis is, and it turned out to be granulocytic sarcoma. And granulocytic sarcomas are a known entity in mixed germ cell tumor because of isochrome 12p mutation. So that was a very new experience for me, that CD15 is helpful in histiocytic sarcomas and AML, especially the M4, M5. Coming to small brief description about T cells, innate immunity, which are gamma delta T cells, which home the mucosal areas like the spleen or the GI or oral mucosa. Adaptive immunity, which is played by alpha beta T cells, and yes, lymphomas of gamma delta T cells are commonly seen in children and young adults, and they include the mucosal sites, while alpha beta T cells are commonly seen in the adult patients. CD4 plus T cells are very important. I would like to go briefly bit about CD4 plus T cells. CD4 plus helper T cells, definitely the number is more for CD4 plus T cells. They can be Th1, Th2, and T regulatory cells. The Th1 cells help other T cells and macrophages, which produce by producing interleukin 2 and interferon gamma. Th2 cells, which produce IL-4, 5, 6, and 10 and help B cells in production of antibodies. T regulatory cells are very important. The Prashant sir discussed a case about adult T cell leukemia lymphoma, but that case was showed some unusual feature, that it was CD25 positive, but clinically and all other markers were positive for ATLL. But ATLL arise from regulatory T cells. So regulatory T cells express FOXP3 and CD25. These two are very important markers to diagnose adult T cell leukemia lymphoma. Then cytotoxic granule-associated proteins, they are positive in METL is very important, like monomorphic epitheliotropic intestinal T cell lymphoma or enteropathy-associated T cell lymphoma. The enteropathy-associated T cell lymphomas are associated with celiac disease. So they have a mixed inflammatory background in them. And they are actually the lymphomas of alpha-beta T cell type, while monomorphic epitheliotropic intestinal T cell lymphomas are of gamma delta T cell type. So they are positive for CD3, but they are negative for CD8, and they are only positive for TIA1. While EATL, they are of alpha beta cell origin, alpha beta T cell origin. So they will be positive for CD3, CD8, and CD7. PD1 plays a role in angioimmunoblastic T cell lymphoma, though the T follicular helper cells, which home the lighter zone of the germinal center, they are also positive for PD1. CD25 and FOXP3 we have discussed. ALK1 may show nuclear and cytoplasmic positivity depending on the fusion partner. If it is the nuclear phosphomin, then it may show any of these patterns. If it is cytoplasmic, if it is CTLC is the partner, fusion partner, then it will show cytoplasmic positivity. I'll not go into the structural framework. These are for pathologists. How to assess the lymph node? We see the capsule, we see the fibrous trabeculae, we see the lymphoid follicles, we see the germinal center, whether there is differentiation between the, in follicular lymphoma, what we see crowding of follicles. They are very much closely opposed together, and they are all of similar size. In a reactive node, the germinal centers are of variable sizes. Some have more antigen exposure, which are of, then the germinal center will be larger in size. Some have lesser exposure, so germinal center will be smaller in size. But in follicular lymphoma, all the germinal centers will be of similar size, and they will be crowded together, and there will be loss of dark and light zone differentiation. There will be absence of tangible body macrophages. So we have to assess the lymph node on low power, then we go to the high power to see the cytology. A pathologist also should be looking beyond the microscope, like age. Some of the lymphomas are common in childhood and some are common in old, mid to adulthood or old age. You people are better aware of all these clinical features. Site is again gives a very good clue that what should we look upon, like in skin, like primary cutaneous follicular cell lymphomas, cutaneous T cell lymphomas or mycosis fungoides. In mediastinal, the classical lymphoma, classical Hodgkin lymphoma, primary mediastinal B cell lymphoma, and ALK positive ALCL are particularly common. In oral cavity, the plasmablastic and Burkitt lymphoma are common, and large B cell lymphoma with IRF4 rearrangement. In upper respiratory tract, extranodal NK T cell lymphoma is common, and lower respiratory tract lymphomatoid granulosis is common. Lymphomatoid granulosis is a B cell lymphoma. Both are angiodestructive, angioinvasive, but the cell of origin is different. The upper respiratory tract extranodal lymphoma is either NK cell or T cell based. Then we have discussed the small intestinal lymphoma, peritoneal or pericardial, pleural cavities, primary effusion lymphoma. They are also seen in immunosuppressed and commonly associated with EBV. So these are the immunodeficiency associated lymphomas. Latency in EBV is also a very difficult topic to remember. What kind of latency is seen in which type of lymphoma? Commonly, these three markers are done to check the latency. And EBER remains positive in all the types of latency. So EBERish is the most important marker which should be assessed in cases where we are dealing with the immunocompromised lymphomas. EBER remains positive throughout the spectrum of EBV associated lymphomas. LMP comes positive in Hodgkin lymphoma, and EBNA1, all three are positive in immunodeficiency associated lymphomas. So this may give some lead to the diagnosis. So these are the morphology and IHC panels of some common lymphomas. We have discussed this. When the lymphocytes are small, one should suspect a small cell lymphoma or small lymphocytic lymphoma or mantle cell lymphoma. When there is follicular architecture, one should suspect follicular lymphoma. One should go for all the B cell lineage along with BCL2 and cyclin D1 to rule out the follicular variant of mantle zone lymphoma. Mantle zone lymphoma is a very notorious entity, and it's traditionally considered as a high-grade B cell lymphoma, and it is not actually, it does not transform to DLBCL. It's already a high-grade B cell lymphoma, and mantle cell lymphoma can present as any in any form. It can present as anemia. It can present as leukemia with splenomegaly with no lymph nodes. It can present exclusively with lymph nodes, or it may present with leukemia only. Then diffuse sheets, if it is composed of large cells, then DLBCL should be first kept in mind. And yes, for mantle zone lymphoma, we have discussed that SOX11 is more important. I think I will come to the cases directly. So coming to the case 1, this is 20-year female presented with multiple discrete cervical nodes in level 2, 3, 4 of size up to 2.5 centimeter, and no other abnormality. And the patient was suspected whether lymphoma or tuberculosis, and FNAC was done outside, which reported as hyperplasia. So we can see this is a low PAR, and we can see this fibrosis which is encircling a nodule, and this diffuse infiltrate. So there is definitely effacement of the architecture. We can see this thickened capsule. So thickened capsule means that there is some chronic lymphoproliferative disease. It's not an acute disease. Acute diseases do not allow the capsule to grow and to allow its increase in thickness. So chronic diseases used to show a reaction for the capsule, and the capsule becomes thickened. Then here we can see these. Can you see, appreciate these large cells? These are very big cells which are surrounded by monomorphic or different kinds of cells. But yes, definitely these are large cells. This is a very large cell which is showing eosinophilic prominent large nucleoli. Hello. So here also we can see these are large cells. Some of them are having convoluted nuclei. These are large cells. So we can see that there is effacement of the lymph node architecture, and there are interspersed a good number of population of these large cells. So what are these large cells? These are characteristic HRS cells. Now, what these HRS cells are positive for? These are positive for CD15, CD30, and as I said, that MUM1 is also positive in these cells. So we can see here CD15 is positive in all these large cells. CD30 is positive. EBV LMP is also positive, but with variable intensity. Some are showing good intensity, but some are very moderate to weak, and some are negative also. So they are positive for EBV, they are positive for MUM1, they are positive for CD15 and CD30. Then PAX5 is DIM positive. This is very important, as I said in the initial discussion, that PAX5 is very where this positivity from the surrounding T cells. These are T cells which are forming the rosette around this large cell. So this is DIM positivity. Here again, another RS cell, another RS cell. All these RS cells are showing DIM expression of PAX5. So this DIM expression is helpful. Then this is CD3. We can see the rosetting present around these large cells. See, this is a beautiful picture of this large RS cells, and CD3's positive cells are forming the rosette around them. This is another, these are CD20. CD20 is also helpful. The clinician, once the diagnosis of Hodgkin lymphoma is made, the next question the clinician will ask is CD20 is positive or not. So CD20 is a mandatory marker for Hodgkin lymphoma, and the pathologist should assess very carefully whether the large cells are positive for CD20 or negative. So here we can see this large cell which is surrounded by the T cells. These are negative for CD20. So the diagnosis was classical Hodgkin's lymphoma, nodular sclerosis type, cellular phase. They have three different phases. The cellular phase, which have very occasional fibrotic septa, are called as cellular phase. Then there is complete fibrotic stage also, where it becomes even difficult to assess and hunt these large RS cells. Now coming to case 2. Case 2 present is a 34-year female presented with weakness, body aches, and cough for 1 month. CT abdomen showed few retroperitoneal lymph node. Endoscopic ultrasound showed multiple enlarged periportal lymph nodes suggestive of lymphoproliferative disease. PET CT was done, and the lymph nodes were metabolically active. So this case was very difficult for me. As I discussed in the beginning, that the lymph nodes which are deep seated are difficult to assess because the needle biopsy is done, and to assess and to give the diagnosis of a lymphoma, that to a high grade lymphoma in a needle biopsy, becomes very difficult and challenging. So this was the case here. It was initially biopsied, a needle biopsy was done, and the needle biopsy had a lot of artifacts. It was showing a lot of crushing, and I could not comfortably call it as a lymphoma because all the cells were T cells. So I raised the possibility it can be a PTCL, but I asked for a excision biopsy. So finally, a laparotomy had to be done in this patient, and even after the laparotomy, the diagnosis was very difficult because it is a very unusual and very uncommon entity. So here we can see this is vaguely a nodular architecture which appears to be mottled in appearance or moth-eaten appearance. These are the nodules actually, and we can see here these nodules are quite pale. Some pale areas are there. So these pale cells are actually, these are histiocytes. So one should, there is one very important finding which could be easily missed because these cells are less in number. You can compare these cells, the number of these cells in earlier case, in Hodgkin lymphoma, the large RS cells were so frequent and they could be easily picked up. But here these large RS cells are very less in number, and importantly, they are surrounded by a rosette. This was finding which was also missed by me, and I I really repent my observation that I missed this observation. So initially I missed these large cells, which were so difficult to pick up from a reactive background. And the second thing which I missed was the rosetting. So this rosetting is very important. And when the cells, when the low power is showing this mottled appearance, moth-eaten appearance, and these large cells are less in number and they are surrounded by this rosetting, classic rosetting. Here also we can see these large cells like this one. You can see this large cell which is surrounded by this wreath of cells. Again, in yes, here also we can see this large cell which is surrounded by a wreath of small cells. Like here, this is a large cell surrounded by a wreath of cells. So it was very difficult because these large cells are less in number. So this kind of moth-eaten appearance with lesser number of large RS-like cells with lot of reactive lymphocytic background and a deep-seated lymph node, one should suspect NLPHL. So NLPHL is a very difficult diagnosis. And in fact, when the histiocytes are more in number, it becomes even more difficult to differentiate it from THR-BCL, T histiocyte-rich B-cell lymphoma. And actually, maybe this year we are going to get the new WHO classification, and maybe they will merge the NLPHL to THR-BCL, or they will remove the one of those type morphological variants of NLPHL, and they will merge with it with THR-BCL. So we can see here that the background, lymphoid rich background, is actually CD3 positive, and this, I guess, this is PD1. I think this was PD1. Actually, it is hidden from this bar. So yes, CD3 is again positive. We can see these rosettes. These rosettes are not to be missed and should be looked carefully, very carefully, that these large RS cells are surrounded by these T cell rosettes. This is PD1 positive. So PD1 is forming PD1, CD2, CD3 are forming the rosettes around these large cells. CD20 is positive. Now these large RS cells are CD20 positive, and they were also positive for BCL6. And they were positive for CD79A, and CD45 was heterogeneously positive. So all these markers, as I said, in Hodgkin lymphoma, there is switching off of BCL2 program, but in NLPHL, the BCL2 markers remain positive. So here these large RS-like cells are positive for CD20, CD79A, and BCL6. So, and these RS cells are scattered or less in number with moth-eaten or mottled appearance, and CD30 was weak and not strong positive like in Hodgkin lymphoma. CD30 may be positive, can come positive in NLPHL. This is, I think, CD15. Ki67, we can see the Ki67, it is more in the lighter zone. We have 5 more minutes. And PAX5 is dim positive. So the diagnosis was nodular lymphocyte predominant Hodgkin lymphoma. So this is a case of review. This we can see the follicles are arranged back to back, and they are positive for BCL2. So this was a case of follicular lymphoma. This is CD23 highlighting the antigen dendritic meshwork, and CD10, the spillage of CD10 positive cells outside the follicles. This is another case, 35-year female presented with a history of sore throat for 2 years. So we can see this is squamous mucosa and the underlying lymphoid cells, which are very large size and showing frequent mitosis. CD3 is showing dispersed positivity, and CD20 is diffuse and strong positive. So the diffuse positivity of for a particular marker is very helpful to assess whether we are dealing with a lymphoma or a reactive process. This is CD10, which is negative. BCL6 is positive. So BCL6 positive, CD20 positive. Cyclin D1 is negative. And this is, I guess, BCL2 is negative, and K67 was very high. So it was a DLBCL, germinal center B cell type. Case 5, 50-year female, a large necrotic nodal mass in portocaval location. So a patient presented with a recurrent symptoms of reflux disease, and endoscopy showed gastric wall thickening and ulceration. So, and perigastric nodes were also there. We can see these are the gastric glands, and the surrounding interstitium is surrounded by large size cells. Here, this is gastric mucosa, and the interstitium is infiltrated by large size cells. So, CD3 was interspersed, and CD20 was diffuse and strong positive. Then BCL6 was positive, and CD10 was negative. BCL2 was positive, and this is c-MYC. So BCL2 positive in more than 50% of cells and c-MYC positivity in more than 40% of tumor cells. That means that this could be a double hit lymphoma. So we can call it as a double expressor lymphoma. MUM1 was also positive. Ki67 was very high. So it was diffuse. Sorry, this case is not. I think I have wrongly labeled the case. This was the case actually, smooth stricture of GE that was activated B cell lymphoma. This case showed BCL6 negative, BCL2 positivity, and c-MYC was positive in this case. Then case 7, multiple swellings in the inguinal region. This was a case which I discussed initially. We can see here that the large number of endothelial cells and with starry sky pattern. Starry sky pattern is not only characteristic of Burkitt lymphoma, it can be seen in any high-grade lymphoma. So this arborizing capillaries with large size cells surrounding these vessels, and the cells were diffusely and strongly positive for CD5 and CD3. CD4 was also positive, and CD7 was also positive. Ki67 was very high. It was negative for CD10 and BCL6. CD20 showed scattered positivity. So we labeled it as PTCL-NOS. 37-year male who presented with a significant weight loss and was on ATT for past 1 year. Duodenal biopsy and lymph node biopsy and CSF aspirate was done. This was a very interesting case. This patient was taking ATT for last 1 year and was not responding to ATT. This patient had significant weight loss and came to the infectious department here in our hospital. The duodenal biopsy was performed due to his intestinal continuously persisting diarrhea. And the duodenal biopsy showed very interesting finding. They were positive for Cryptococcus. So all this soap bubble appearance is of Cryptococcus. These are the special strains which we performed. This is mucicarmine, DPAS, and GMS. This was a lymph node. Every site of this patient was filled with Cryptococcus. CSF, lymph nodes, GI biopsies. This was case of disseminated cryptococcosis. 3 months later, the patient presented with a chest pain and was evaluated again with a chest X-ray. The chest X-ray showed a lytic lesion in the ribs and a mass in the liver. So liver mass was initially FNAC'd. On FNAC, I saw the large cells which I raised for which I raised the possibility of plasmablastic lymphoma, but I advised a biopsy. So biopsy was performed. The biopsy showed very large cell infiltration in the sinusoids and in the portal areas. These large cells were positive for CD3 and CD20 was negative. CD45 was positive, PAX5 was negative, and CD79A was negative. So, any differentials? So, this is CD45 positive. And PAX5 is negative, CD79A is negative, CD20 is negative, but the cells are positive for CD3. Let's come to next panel. CD2 is also positive, CD5 is positive, and CD4 is positive, and CD8 is negative. Now, anyone who can guess the diagnosis? So, initially, I considered it as a plasmablastic lymphoma. But to my surprise, the cells were negative for CD38, CD138, and they were positive, but they were positive for MUM1. MUM1 positivity initially drifted me towards plasmablastic lymphoma, but when the cells turn out to be diffusely and robust positivity for CD4 and CD2 and CD5, so I considered that it's a it could be a T cell lymphoma. Then I tried to rule out ALK positive or ALK negative ALCL. ALK was negative in this case, and EMA was also negative. So EMA can be negative, and CD30 was the most interesting finding. I think I skipped the CD30 slide. CD30 was the most important clue. CD30 was strong and diffuse positive. which is unlike in plasmablastic lymphoma. So plasmablastic lymphoma may show CD30 positivity, but it will be never diffuse and very strong. So I made the diagnosis of ALK negative ALCL. So every the clinical aspects and the morphological and immunohistochemical features were going towards plasmablastic lymphoma, but based on IHC, it turned out to be ALK negative ALCL. Ki67 was very high, and EBV-LMP was negative. No, we did not perform DUSP2 because of unavailability. Yes,
30% of these could be those, and their prognosis is same as ALK positive.
Sorry.
Prognostically, it's a similar group as DUSP2 positive.
Yes. Yeah. They are actually 30 to 50% of such
lymphomas. 30% of ALK negative
turn out to be DUSP.
Prognostically, they're favorable group.
Yes.
So I think we should do. In fact, this patient, I will tell you, this is retrovirus positive disease and very sick, disseminated cryptococcosis on high dose fluconazole also. And we have treated with pre-phase with cyclophosphamide. Vincristine has drastically improved now. And we, luckily we applied for the compassionate brentuximab program, and he has got approval for that. So I think we'll be using a brentuximab based regimen for him. But he was nearly PS4 and probably more than that. He was very sick when we started.
Yes, DUS P22 is not available, but it is mutually exclusive with TP63, for which the IHC does well. So if you have that IHC, so you can put it, and if it is positive, you can assume that this is negative. So that could be done.
P63 is positive, and you want to still, because P63 positivity still does not confirm TP63. So for that, FISH has to be done confirmatory, yes. But it is a great point. I think that's also a prognostically better group. So you could.
Thanks for updating me, really.
Worse, yeah. So you could please do that also on this.
Sure. So we are developing our department right now. We have got a lot of markers almost, and we are in process of establishing more number of markers. So the last case, this is also very interesting case. The patient was one of my colleague, and he was 65-year, a very respected doctor. And the patient had resolving and reappearing nodular lesions mainly in the trunk and upper extremities and upper limbs. So the nodules appeared very frequently, and subsequently they regressed spontaneously as well. So, but there was no palpable lymph nodes. The peripheral blood films were normal, differential counts were normal, and the lesions, these nodular lesions, were FDG negative and were not FDG avid. So this is a skin biopsy. We can see that the overlying epidermis and the entire dermis and subcutis is involved by this lymphoid monomorphic population. Here we can see this is epidermis and the cells are monomorphic. There was epidermotropism also. And these cells showed
mitosis. Last 1 minute, Gaurav.
Yes. Last case. So these were positive, these were negative for CD20, and CD3 was diffuse and strong positive, PAX5 was negative. So any guesses? Nodular lesions arising in upper extremities and chest, diffusely positive for CD3, but negative for CD20 and PAX5. Any differentials? CTCL. Okay. Mycosis fungoides. Okay. So mycosis fungoides have typically patch, plaque, and tumor stage. They will not go directly into the tumor stage. So what I am trying to tell you that the presentation was tumor like nodules. It was in nodular stage. So suddenly nodule appears and they disappears. LYP, lymphomatoid papulosis. Yes, the diagnosis is lymphomatoid papulosis. So CD4 was positive, CD30 was strong and diffuse positive, CD5 was negative, and 8 was also negative. We did EBV, LMP, MUM1 was positive, CD7 was positive, but Ki67 here does not play much role because they are good prognosis diseases. But yes, the close differential of this case is cutaneous ALCL also. And again, we are suspecting that cutaneous lymphomas will also merge the overlapping entities, like the type C type of lymphomatoid papulosis is very much similar to cutaneous ALCL. They are positive for CD30 and they are negative for ALK1, though they are called as ALCL. So the characteristic clinical appearance is that of nodule which appear and then they disappear. Even some people don't think that they should be treated, but some people try methotrexate or steroid applications. So the lesion can disappear within 3 to 12 weeks and may leave behind superficial scars. They may be preceded or associated or followed by another type of cutaneous lymphomas. These are the 6 types. Type E is which shows very high grade kind of presentation. They may be associated with necrosis and ulceration. And type D is strongly epidermotropic. Type C, which shows CD30 positive atypical cells, CD4 positive, and inflammatory cells are few in background. They are similar to cutaneous ALCL. Probably this will be merging with the cutaneous ALCL. Thank you.